Now the next topic is motor neuron diseases. In motor neuron diseases are the diseases affecting motor neurons only. Affecting motor neurons only. The cortex contains cell bodies called beds or pyramidal cells. Okay, now the cortex, it contains the cell bodies which are known as the beds or pyramidal cells, whereas the tracts contain bundles of axons. Okay, so basically up till now what we have covered, it is so simple that motor neuron diseases, they are the diseases which affect the motor neurons only, and the cell bodies are present in the cortex. Okay, and these cell bodies are known as the beds or pyramidal cells. Okay, the cell bodies present in the cortex are beds or pyramidal cells, and the tracts, they contain the bundles of axons only. After that, the cell bodies present in the anterior horn of gray matter. The cell bodies which are present in the anterior horn of the gray matter, they are known as anterior horn cells. Okay, so now motor neuron diseases, they are the diseases which affect the motor neurons only, and the cortex, it contains the cell bodies which are known as the beds or pyramidal cells, and the tracts, they contain the bundles of axons. The cell bodies which are present in the anterior horn of the gray matter, they are known as the anterior horn cells. Okay, after this, the upper and lower motor neurons form a two neuron circuit. Okay, the upper motor neurons, UMN, they originate in the cerebral cortex. Originate in the cerebral cortex only and travel down to the brainstem. The upper motor neurons, they originate in the cerebral cortex and they travel down to the brainstem or the spinal cord. Okay, while the lower motor neurons begin in the spinal cord and go on to innervate muscles and glands throughout the body Now upper motor neuron, it is the corticospinal tract, and lower motor neuron is the anterior horn cell of neuromuscular junction. Okay, till now. Okay, so now correlating this whole info, we can say that the upper motor neuron, okay, usually a two neuron circuit is present in the brain and the spinal cord. Okay, a two neuron circuit is present in the brain and the spinal cord. The upper motor neurons, okay, they originate in the cerebral cortex as cell bodies known as beds or pyramidal cells, and they travel down to the brainstem or spinal cord as bundles of axons or tracts. While the lower motor neurons, they begin in the spinal cord as cell bodies present in the anterior horn of gray matter, which are known as the anterior horn cells, and to go on to innervate muscles and glands throughout the body. Now upper motor neuron is the corticospinal tract and lower motor neuron is the anterior horn cells of the neuromuscular junction. Okay, now just a simple diagram in this case. So till now, this is a short summary of what we have studied till now through this diagram. This is the brain, okay, and in brain this is the primary motor cortex, and this is the spinal cord, and this is the end muscle, okay. And the cell bodies of upper motor neurons, that is the pets or pyramidal cells, they are present in the motor cortex, and then they travel their axons or bundles of axons or tracts that travel through the spinal cord as the upper motor neurons, as shown in this cross section of the spinal cord. And after entering the spinal, they come in contact with the anterior horn cells. The cell body is present in the anterior horn of the spinal cord or of the gray matter, which is known as the lower motor neuron, and then it penetrates the muscles as neuromuscular junction. Now through other image, for example, again this is the motor cortex, okay. In this there is decussation in the medulla, okay, medulla. This is the lower motor neuron, and over here we have a corticobulbar tract. We are talking about the corticobulbar tract, and this is the hypoglossal nucleus. These are the pyramids, okay. Then we get a hypoglossal nerve, that is the cranial nerve number 12. This is a gene, okay. After coming out from the motor cortex and decussating in the medulla, the hypoglossal nerve, it then enters the genioglossus muscle present in the tongue. So this was the diagram related to it. Now coming to the next point. The first order neuron is an upper motor neuron that will synapse with cell bodies inside cranial nerve nuclei. That will synapse with the cell bodies inside the cranial nerve nuclei and form the cell body axon, and from the cell body axon they'll come out through cranial nerves till this supplies to the respective muscle, okay. Now in first order neuron is an upper motor neuron, okay. First order neuron is an upper motor neuron that will synapse with cell bodies. First order neuron, it is an upper motor neuron that will synapse with the cell bodies inside the cranial nerve nuclei, and from the cell body axons will come out through the cranial nerves till this supplies to the respective muscles, okay. That's simple. So over here the cranial nerves, they are acting as the lower motor neurons. Cranial nerve nuclei, okay, from the cell body axons, okay, respective muscles, as shown above over here. Upper motor neuron in corticobulbar tract, it decussates in the medulla, and after that it continues as hypoglossal nerve, okay, which is a lower motor neuron, and then it supplies the genioglossus muscle in the tongue. Now coming to the brainstem. Brainstem has cranial nerve nuclei. Midbrain we have 3,4. In pons we have 5, 6, 7, 8, and in medulla oblongata we have 9, 10, 11, 12. So talking about the brainstem has cranial nerve nuclei. Which cranial nerve nuclei are present in which part of the brainstem? Now first of all we have the midbrain 3 and 4. Okay, midbrain 3 and 4. Pons is important. 5, 6, 7, 8. The word pons, okay, it has 4 letters, and after the letter 4 we have, after the number 4 we have 5, 6, 7, 8. This is the mnemonic to remember, right? Then we have the medulla oblongata. Since this is a huge name, it is going to have huge numbers 9, 10, 11, 12. Well, 9 is my roll number also. After that, damage anywhere in the motor cortex, subcortex, till the neuron reaches the medulla oblongata is upper motor neuron, damage to cranial nerves, okay. Now brainstem, we just learned about the basic structure of the brainstem and its associated cranial nerves, okay. Now damage anywhere in the motor cortex or subcortex till the neuron reaches the medulla oblongata is upper motor neuron damage, okay. From motor cortex or subcortex to the medulla, it is any damage to the nerve, it is known as the upper motor neuron damage to the cranial nerve. Now damage at the level of medulla oblongata, affecting the cell bodies in the nucleus or nucleus to the neuromuscular junction, in the nucleus or nucleus to the neuromuscular junction is all element damage. Okay, now what is the lower motor neuron damage? Damage at the level of medulla oblongata, which affects the cell body in the nucleus or nucleus to the neuromuscular junction, is all lower motor neuron damage. Now coming to the next topic, that is corticobulbar tract. Corticobulbar tract. Corticobulbar tract. These are the neurons traveling from the cortex to the brainstem. Now what is bulbar palsy? In bulbar palsy, lower motor damage to multiple cranial nerve nuclei present in the medulla oblongata. Okay, now what is a bulbar palsy? Bulbar palsy is the lower motor neuron damage to multiple cranial nerves. Okay, it is a lower motor neuron damage to multiple cranial nerve nuclei present in the medulla oblongata. Bulbar palsy. After, it means that the pathway is affected after leaving the medulla oblongata. For example, in the above example, we can take it as damage to the hypoglossal nerve. Now, pseudobulbar palsy. In pseudobulbar palsy, there is upper motor neuron damage to corticobulbar tract. There is upper motor neuron damage to the corticobulbar tract. Pseudobulbar, upper motor neuron. Okay, since it has two U's, so upper motor neuron. Since it has one U only, lower motor neuron damage. Now, what are the clinical features? This question is important actually. Clinical features of bulbar and pseudobulbar palsy. Usually, three things are common in bulbar and pseudobulbar palsy. 3 Ds. Okay. Number 1, it is dysarthria. That is difficulty in articulating words, difficulty in speaking. Dysphonia. Now, what is dysphonia? Dysphonia, it is basically an abnormal voice or difficulty in producing vocal sounds. That is, there can be change in pitch, volume, tone, or quality of the voice. Dysarthria, difficulty in articulating words. Dysphonia means there is changes in the pitch, volume of the voice, and dysphagia. Dysphagia. Dysphagia means the partial loss or impairment of language ability. Partial loss or impairment of the language ability. Okay. Phasia is usually related to language only. Now, there's some few important points. Jaw jerk. Okay. Jaw jerk. It is present in upper motor neuron injury, that is pseudobulbar palsy. And again, we can see 2 U's in a W. Okay. So, jaw jerk, pseudobulbar palsy, and upper motor neuron lesion. And absent or decreased in bulbar palsy. After this, nasal regurgitation. Nasal regurgitation. We will only see the first word for the mnemonics. Nasal regurgitation of food suggests. Okay, or we can also see that again there is only one U of food suggests bulbar or lower motor neuron type of palsy due to reduced tone of muscles. As it is reduced tone of muscles. Now, small table. Sorry. Okay, now just a small table. On the features, pseudobulbar palsy and bulbar palsy. Okay, now first of all, gag reflex. The gag reflex. Okay, due to the cranial nerve 9 and 10. Okay, it is usually normal or increased in pseudobulbar palsy, and also we can remember that jaw jerk, was present in pseudobulbar palsy too. So these kinds of reflexes, they kind of seem to increase in pseudobulbar palsy, whereas they were absent in bulbar palsy. Now coming to palatal movement. In palatal movement due to cranial nerve 10. Okay, cranial nerve 10 leads to palatal movement. It is absent in both pseudobulbar and bulbar palsy. Since both pseudobulbar palsy and bulbar palsy, they both have a P in it, and palatal movement also, so it is absent in these two. Gag reflex, palatal movement, speech. Now coming to speech, that is cranial nerve 10 again. There is spastic dysarthria, labored speech, or flaccid dysarthria, such as nasal twang. Okay, first of all, till now we studied about the gag reflex, okay, the palatal movement and the speech. The gag reflex in pseudobulbar palsy and bulbar palsy, the palatal movement and the speech. Okay, the gag reflex, it was normal increase in pseudobulbar palsy. In bulbar palsy, it was absent. In palatal movement, these two were absent in speech. In pseudobulbar palsy, there was spastic dysarthria. Okay, there was labored speech. And flaccid dysarthria means there is a nasal twang. Now, why spastic dysarthria is seen in pseudobulbar palsy? Okay, now what is dysarthria? It is a motor speech disorder which is caused by impaired control of the muscles used for speech, okay, due to some neuromuscular lesion. Now what happens is that there is loss in corticobulbar tract or upper motor neuron region in pseudobulbar palsy. There is loss of voluntary control of muscles of speech, swallowing and facial muscles. There is loss of voluntary control, okay, voluntary control of muscles of speech, swallowing and facial expression. So this leads to pseudobulbar palsy. Okay, now in upper motor neuron region there is spasticity or increased tone or stiffness. Okay, so speech becomes slow, strained and effortful. Okay, spasticity. Obviously upper motor neuron leads to spasticity because the lower motor neuron, it loses control from the brain, whereas in case of bulbar palsy, since lower motor neuron also loses control over the muscle, it leads to flaccid dysarthria, that is flaccidity or flaccid dysarthria, that is nasal twang. Till now we studied about the gag reflex, the palatal movement and the speech, and the last one is the tongue. Cranial nerve 12, not 11, 12. Okay, since in pseudobulbar palsy it will lead to small and tight, cannot be protruded, lies on floor of mouth, okay, kind of tongue, and wasted and thrown into folds. The bulbar palsy is wasted. In case of bulbar palsy, the tongue is wasted and thrown into folds, and motionless fasciculations may be present. In bulbar palsy, the tongue is wasted and thrown into folds, motionless, and fasciculations may be present. Now coming to the classification of motor neuron diseases. Okay, next important topic is the classification of motor neuron diseases. In this case, first of all, talking about the pure upper motor neuron disorders. Mainly these are pure upper motor neuron disorders only. These are usually neurodegenerative. Okay, these can be neurodegenerative, toxin mediated, infection mediated, inherited, okay, pure upper motor neuron disorders. First of all, neurodegenerative disorders. In this we have primary lateral sclerosis, that is PLS, which affects the lateral corticospinal tract. In neurodegenerative, there is primary lateral sclerosis. In pure upper motor neuron disorders, it is primary lateral sclerosis and it affects the lateral corticospinal tract. Toxin mediated upper motor neuron disorder, it is seen in letharism. Letharism due to BOA, that is beta N oxalyl amino L alanine, beta N oxalyl amino L alanine. Okay, in pure upper motor neuron disorders, they are usually neurodegenerative, that is there is primary lateral sclerosis, PLS, which affects the lateral corticospinal tract. toxin mediated through lethallism, and infection mediated by HTLV1 and 2, and both cause HTLV associated myelitis. Affecting the corticospinal tract. Inherited, it is seen in hereditary spastic paraplegia. Inherited, it is seen in hereditary spastic, spastic paraplegia. That's all. Now in pure lower motor neuron disorders, we have, first of all, neurodegenerative disorders. In neurodegenerative, we have progressive muscular atrophy. PM. In pure upper motor neuron, there was primary lateral sclerosis, and in pure lower motor neuron disorders, we have progressive muscular atrophy, in which there is damage to lower motor neuron, and in case it is infection mediated, it is due to poliomyelitis, affecting the anterior horn cell of spinal cord, affecting the anterior horn cell of spinal cord. Okay, in case of neurodegenerative, there is progressive muscular atrophy, as there is damage to the lower motor neurons, and infection mediated, there is poliomyelitis, affecting the anterior horn cells of the spinal cord. And at last, we have inherited. In inherited, we have spinal muscular atrophy, SMA, affecting the anterior horn cell, and in mutation in SMN1, there is survival of motor neuron 1 gene, and in treatment we have onesemno gene. Just remember the name onesemno gene. And in both upper motor neuron and lower motor neuron lesions, we have amyotrophic lateral sclerosis, ELS, and we have Madras motor neuron disease. Okay, Madras motor neuron disease too. Okay, and ALS plus sensorineural deafness plus optic atrophy. Okay, ALS plus sensorineural deafness plus there is optic atrophy. Another topic, ALS, is left after the short break. Okay, so the next topic is amyotrophic lateral sclerosis, something that Stephen Hawking was suffering from. Amyotrophic lateral sclerosis. Okay, it is also known as Lou Gehrig's disease. Motor nerve disease. It is a motor nerve disease involving both upper motor neuron and lower motor neuron. I sometimes think that if another person is sleeping, and in case you whisper something in the ears of the sleeping person, then can that person who is already sleeping dream those things that the another person is saying in its ear? I don't know what I'm saying, but yeah. Imagine controlling someone's dreams like this. Okay, it is a neurodegenerative disorder. Okay, till now what we have studied, amyotrophic lateral sclerosis. It is a neurodegenerative disorder which involves both upper motor neuron and lower motor neuron, and it is also known as Lou Gehrig's disease. Okay, after that, 90 to 95% are sporadic and called sporadic amyotrophic lateral sclerosis. Okay, SALS. Whereas 5 to 10% are familial, called familial amyotrophic lateral sclerosis, false. Now coming to its epidemiology. I don't know why we are made to study this much of theory, even we are only gonna learn it through clinics and internship only, but I think this helps in making a strong base. I hope so. In only if we are able to keep this much of knowledge in our mind with quite repetition, then we will become an excellent doctor. Becoming a doctor is easy, but becoming an excellent doctor, it takes some guts. Okay, the first disease which we have studied, in which the males, they are more affected as ALS. Just remember Stephen Hawking. Okay. Now what is the age of onset? In this case, the age of onset is more than 50 to 60 years in genetics. Now talking about the genetics, the most common 40% mutation C9orf72. It also causes BVFTD, that is behavioral variant FTD. Now, actually remembering this type of bullshit is not really important, but it sometimes get asked for 1 mark question. And life, it is not really that important. But okay, talking about the genetics and how to remember the genetics of ALS. Genetics of ALS. The most common mutation is C9orf72. Cristiano Ronaldo football. Cristiano, I don't know. No, Ronaldo, I don't know. Football 72. I don't know what I'm saying, but it is easier to remember. And it also causes BVFTD, behavioral variant FTD. Okay, after this, there is also mutation in the SOD1. And there is again mutation in the TDP43. That is transactive response DNA binding protein. Transactive response DNA binding protein 43. Now, mean survival after symptom onset, it is around 3 years. Duration is 9orf72, SOD1 and TDP43. Now, what is the pathology related to it? Since it is a neurodegenerative disorder involving both upper motor neuron and lower motor neurons, there is ubiquitin immunoreactive inclusions. Ubiquitin immunoreactive inclusions and other inclusion bodies like Bunina bodies. And last but not least, TDP43 can also be detected. Now, what are the clinical features? In clinical features, it is 75% spinal form, that is asymmetric weakness usually. It starts in the upper limb and then eventually involves the lower limb, and then eventually involves the lower limb. Okay, in clinical features, it is 75% spinal form, that is there is asymmetric weakness. Okay, that usually starts in the upper limb. Asymmetric weakness is there that usually starts in the upper limb and then it eventually involves the lower limb, and 25% it is bulbar form, that is bulbar palsy plus pseudo bulbar palsy is there. In 25% bulbar form, there is bulbar palsy plus pseudo bulbar palsy. As both upper motor neuron and lower motor neuron are involved, and there are 3 Ds in presentation, that is dysarthria, dysphonia and dysphagia. They have the worst prognosis. Then coming to the split hand sign. Dissociation of muscle weakness in the hand. There is dissociation of muscle weakness in the hand. In the hands, there is dissociation of muscle weakness in the hands. Thenar muscles are disproportionately wasted as compared to the hypothenar muscles. Look at the thenar muscles. The thenar muscles, they are disproportionately wasted as compared to hypothenar muscles is a useful clinical sign for bedside diagnosis of ALS. Is a useful clinical sign for bedside diagnosis of ALS. Now coming to the diagnosis of ALS. There is a revised EL or Escorial criteria. Clinically definite ALS if it is a clinically definite ALS if more than or equal to 3 regions showing UMN and LMN. Finding that it is somewhat similar to the McDonald's criteria which we had studied earlier, but in this case in the revised Escorial criteria we can say that ALS is clinically definite, that is either through MRI findings or something similar to that. We can say that if more than or equal to 3 regions, they show LMN, UMN and LMN findings. More than or equal to 3 findings. Okay. Now, Awadi-Shima criteria. Awadi-Shima criteria. In this, it is a clinically definite ALS if there is bulbar or pseudo-bulbar plus upper motor neuron plus lower motor neuron involvement in more than or equal to 2 regions. Okay, Awadi-Shima criteria. In Awadi-Shima criteria, it is clinically definite ALS if there is bulbar plus or pseudobulbar plus UMN plus LMN involvement in more than or equal to 2 regions, and after that there can be more than or equal to 3 spinal regions showing UMN plus LMN involvement. This is just similar to the upper criteria, the L Escorial criteria. Now in MRI, what are we going to find? In MRI, we are going to find hyperintensities signals in T2 flare. Hyperintensities were seen in T2 flare sequences only. We studied earlier in internal capsule. We studied it earlier in multiple sclerosis. Now management of ALS. This is the last topic. In management of ALS, first of all, we have supportive care. Second, we have pharmacotherapy. And third, we have newer drugs. Okay. In supportive care, we have motor weakness. In supportive care, we have motor weakness. For example, in this, we can give the patient a wheelchair. Motor weakness is there. Then second one, we have dysarthria. In this, treatment is voice synthesis therapy. Number 3 is dysphonia. Again, the treatment is voice synthesis. Dysphagia. There is PEG, percutaneous endoscopic gastrostomy tube. And this there is percutaneous endoscopic in dysphagia, there is PEG, percutaneous endoscopic gastrostomy, not that usual patiala PEG. And in the pharmacotherapy, we have riluzole, not eculizumab, natalizumab, like we studied earlier, and ocrelizumab. Okay, remember that. And riluzole. Then we have edaravone. These in pharmacotherapy, these medications, they increase survival by a few months. Now in newer drugs, we have tofersen. Tofersen, it is an antisense oligonucleotide targeting SOD1 gene. Riluzole, edaravone, these medications increase survival by a few months. Tofersen is an antisense oligonucleotide targeting SOD1 gene. Tofersen is a newer drug. It targets the SOD1 gene. That's all.